Hello friends, hope you are all doing well. Today our topic for discussion is diabetes in pregnancy management from preconception to the postnatal period. This is the NICE guidelines published 25th Feb 2015 and last updated 16 December 2020. Now we have to continue with that. What are the preconceptional planning and care? Information about the outcome and risk for the mother and baby. Provide information, advice, and support to empower women who have a positive experience of pregnancy and to reduce the risk of adverse pregnancy outcomes for the mother and baby. So, preconception counseling usually in that patient, those are non-diabetic, that is type 2 diabetes mellitus, and also in those patients those having a previous pregnancy with gestational diabetes mellitus. So in that case you will also do preconceptual counseling. Explain to the women with diabetes who are planning a pregnancy that if they have a good blood glucose control before conception and throughout their pregnancy, this will reduce the risk of miscarriage, congenital malformation, stillbirth, and neonatal death. But the risk can be reduced but not eliminated. When women with diabetes are planning a pregnancy, provide them that their families with information about how diabetes affect the pregnancy and how the pregnancy affect diabetes. So this information could cover the role of the diet, body weight and exercise, the risk of hypoglycemia and impaired awareness of the hypoglycemia during pregnancy, and how nausea and vomiting pregnancy can affect blood glucose control, the increased risk of having a baby who is large for gestational age, which increase the likelihood of birth trauma, induction of labor, instrumental delivery, and cesarean deliveries. So, the need for diabetic retinopathy before and during pregnancy if the patient is having chronic diabetes mellitus, the need for diabetic nephropathy assessment before pregnancy, the importance of maternal blood glucose control during labor and birth, and the need for early feeding of the baby in order to reduce the risk of neonatal hypoglycemia. The possibility of that the baby may have health problem in the first 28 days and may need admitted to the neonatal unit, the risk of baby developing obesity, diabetes and other health problem in later life. So when the patient present with the chronic diabetes mellitus or previous history of gestational diabetes mellitus, so the preconceptual counseling is very important, because whenever you manage this patient, especially in OSCE station, you have to before starting the treatment, your first the first line of the management would be, first of all I will counsel the patient regarding the treatment and what are preconceptual counseling she should have taken. And after that, for example, if the patient is already in pregnancy and having diabetes mellitus, when completing the whole diabetes process and postnatal care, then you have to tell the patient that she should have early pregnancy, pre-pregnancy counseling. She should have to come early before she is trying to have a baby in later on next pregnancy. So preconceptual counseling is very important. So you have to, in preconceptual counseling, you will tell about the diet, body weight, exercise, and if she is already on insulin or taken hypoglycemic drugs, so you have to tell about that there may be along with that if she does not about the hypoglycemic symptom, you have to tell that there may be sweating, low BP. So you have always there must be a sweet sweet type of thing, or maybe with the patient in every, usually in diabetic patient. So these are the preconceptual planning and care. These are the points you have to tell to the patient that what you have to do and what are. So the next point is the importance of planning pregnancy and the role of contraception. Emphasize the importance of planning for pregnancy as a part of diabetes education, adolescence for women with diabetes. Explain to the women with diabetes that their choices of contraception should be based on their own preference and any risk factors. Advise women with diabetes they can use OCPs. Advise women with diabetes who are planning to become pregnant that the risk associated with diabetes in pregnancy will increase the longer they have diabetes. The use of contraception until they have a good blood glucose control. The blood glucose target glucose monitoring, medicine for treating diabetes, including insulin regimes, medicine for complications of diabetes will need to be reviewed before and during pregnancy. The extra time and effort is needed to manage diabetes during pregnancy. The more frequent contact is needed with health professionals. For women with diabetes who are planning a pregnancy, provide information about the local arrangement for support during, including emergency contact number. So before planning, you must tell the patient if her diabetes has not been controlled. So preconceptional counseling is that you have to continue contraception until her blood glucose level is controlled, because there increased risk of congenital malformations, stillbirth, neural tube defects. So before planning a pregnancy, your blood glucose must be controlled. So dietary supplementation and body weight. Offer individualized dietary advice to the women with diabetes who are planning pregnancy. For women with diabetes who are planning a pregnancy or who have a BMI above 27 kg per meter square, offer advice on how to lose weight in line with the in dietitian, and using variation on the BMI cutoff based on the risk and different ethnic group. So what would be her target BMI? Advise women with diabetes who are planning a pregnancy to take folic acid 5 mg per day until 12 weeks of gestation to the reduce of having a baby with a neural tube defect. So in that case, for example, in which cases you have to give 5 mg folic acid, and those patient those are obese, BMI of more than 30, and those having diabetes mellitus, type 2 diabetes mellitus. And the other thing is that in patients who are sickle cell anemia, and those are having thalassemias, and these are the indication for giving folic acid 5 mg. Otherwise we will give 400 microgram. Monitoring blood glucose and ketones before pregnancy. Offer a monthly measurement of HbA1c level for women with diabetes who are planning a pregnancy. Offer blood glucose meter for self-monitoring to women with diabetes who are planning a pregnancy. If a woman with diabetes who is planning a pregnancy need to intensify blood glucose lowering therapies, advise her to monitor her blood glucose more often, to include fasting level and a mixture of pre-meal and post-meal. Offer blood ketone testing and strip a meter to women with type 1 diabetes who are planning pregnancy. Advise them to test for ketonemia if they are become hyperglycemic or unwell. So and will not advise in type 2 diabetes mellitus, but in type 1 diabetes mellitus there increased chance of ketoacidosis. So in that case you will tell the patient that she should have to check her blood ketone testing. Target blood and HbA1c level before pregnancy. Agree individual target for self-monitoring of blood glucose with women who have diabetes and planning for pregnancy. Take in account the risk of hypoglycemia. Advise women with type 1 diabetes mellitus who are planning pregnancy to aim for the normal capillary blood glucose level range of fasting of glucose of 5 to 7 millimole on waking, and plasma glucose of 4 to 7 millimole before meals at or other times of the day. So this is one of the SBA, that what are the target levels before planning a pregnancy. Fasting of 5 millimole to 7 millimole on waking, and plasma glucose level of 4 to 7 means after meal, before meal, or at other time of the day. So on waking, fasting 5 to 7 fasting, and the plasma glucose should be 4 to 7 millimole. So you have to memorize this number 5747, because this is one of your SPA. Advise women with diabetes who are planning a pregnancy aim to their HbA1c level before 48 millimole per liter. It should be less than 6.5% if it is achievable without causing problematic hypoglycemia. Reassure women that any reduction in HbA1c level toward the target is likely to reduce the risk of congenital malformation in the baby. So this one is also an SPA, that how much you have to aim of HbA1c level to be maintained before planning a pregnancy. That would be 6.5% or 48 millimole per liter. Strongly advised with diabetes, your HbA1c level is above 8.6. 10% not to get pregnant until HbA1c level is lower because of the associated risk. If the but if they have given you that strongly advise women that who are HbA above not to get pregnant. So this one is the cutoff, that if the patient is having 8 point, if more than 6.5 that she can pregnant, we can control. But the patient with 8.6 millimoles, strongly advise that she should not get pregnant because there is more chances of congenital abnormalities or a neural tube defect. Safety of medicine for diabetes before and during pregnancy. Women with diabetes may be advised to use metformin as an adjunct or alternative to insulin in the preconceptional period and during pregnancy, when the likely benefit from improved blood glucose outweigh the potential for harm. Stop all oral blood glucose lowering agent before pregnancy and use insulin instead. So in that they say that preconception metformin or insulin both are best in these cases. And be aware that available evidence on rapid acting insulin analogs as Smart and Lispro does not show an adverse effect on the pregnancy or health of the baby. So use isoflurane insulin, also known as NPH insulin, as a first choice for long-acting insulin during pregnancy. Consider continued treatment with long-acting analogs for women who have established good blood glucose control before pregnancy. So you have to give both if the with the blood glucose level is not controlled with short acting, then you have to add the long acting or intermediate acting insulin for control of our sugar level. Safety of medication for complication of diabetes before and during pregnancy. Stop AC inhibitor or angiotensin 2 receptor antagonist before conception as soon as pregnancy is confirmed. Use alternative antihypertensive that are useful. So if the patient is having diabetes along with the nephropathy, or those having developing hypertension, so if you are if the patient is taking AC inhibitor or angiotensin 2 receptor antagonist, so you have to stop it in collaboration with the multidisciplinary team. So in these cases, whenever the patient present with those having a diabetes, so involvement of multidisciplinary team is very important. We involve the endocrinologist and the specific physician, the neonatologist later on, because it is a joint decision of the patient. Involve dietitian as special nurses for that the care of the patient. So stop statin before pregnancy as soon as the pregnancy is confirmed. Make it easier to women for assess preconception care. For adolescents or onward, at every contact with women with diabetes, health professional, including the diabetes care team, should explain the benefit of preconception blood glucose control. The diabetes care team should record the planned woman for a pregnancy and preconception. Provide preconception care for women with diabetes in a supportive environment. Encourage partner and family members to attend. Education and advice. As early as possible, offer a structured education program with the women who are planning a pregnancy. Offer a preconception care advice before stopping contraception for women with diabetes who are planning pregnancy. So, and retinal assessment is very important. Those are having a type 2 diabetes mellitus. If the patient is having a retinopathy proliferative, like in these cases, so you have to advise to avoid pregnancy. So, retinal assessment is very important in those having chronic diabetes. For women with diabetes who are seeking preconception care, offer a retinal assessment at their first appointment unless they have a retinal assessment in 6 months. If less than 6 months, then you have to not offer retinal assessment. If more than 6 months, then you have to offer a retinal assessment again. Advise women with diabetes who are planning pregnancy to defer rapid optimization of blood glucose until after they have retinal assessment and treatment. Renal assessment. Offer women with diabetes a renal assessment, include measurement of albuminuria before stopping contraception. Consider referring women with diabetes to nephrologists before stopping contraception if serum creat is 120 micromole per liter or more. So you will also involve nephrologist and refer to the patient. You will advise all investigation. Those are chronic diabetes or chronic hypertension. So you have to evaluate the end organ evaluation. So for that renal, there must be that if you before stopping contraception, The serum grade should be less than 120 micromole per liter. Urine albumin catrate ratio is less than 30 mg per millimole, or the estimated GFR is less than 45 per ml per minute, 1.73 meters square. So this one is a one of the SBA, you may have asked in exams that for retinal assessment, how much time is required if the patient is already less than 6 months, no need, and if more than 6 months, then you have to do again retinal assessment. And for renal assessment, the serum creat should be less than 120 micromole per liter, albumin creat ratio less than 30, and estimated GFR is less than 40. You have to memorize this. This is one of the SBA. Then we have to start with gestational diabetes mellitus. Risk assessment, testing and diagnosis. Risk assessment. So in gestational diabetes, you have to assess the risk factors. In journal, every patient in our Asian, they usually in Asian, we have to at an antenatal appointment, because in Pakistan there is the diabetes have been the usually the and those patients young in Asian, they recommend that in every Asian woman must do OGTT at appointment, because क्योंकि जो आपका जिस डायबिटीज़ का जो वो है बड़ा ज़्यादा एक इंसिडेंस है वो बहुत बढ़ रहा है, ठीक है, पाकिस्तान में. सो रेशो बहुत ज़्यादा बढ़ गया, तो इस वजह से इन they recommend that in every Asian woman you have to do OGTT at booking. So, to help women make an informed decision about risk assessment and testing for gestational diabetes, explain that some women find that gestational diabetes can be controlled with change in diet or exercise. Most women with gestational diabetes will need oral blood glucose lowering agent or insulin. If gestational diabetes is not detected and controlled, there is a small increased risk of adverse birth complications such as shoulder dystocia. Women with gestational diabetes will need more monitoring and may need more intervention during the pregnancy and labor. So the risk assessment for gestational diabetes mellitus in healthy population, to at booking appointment, check the following risk factor. So the first one, every woman when present with you, and you have to assess the patient at booking. So in that case, you have to check her at booking her BMI. If the BMI is above, to check her BMI, if the BMI is above 30 kg per meter square, so this patient has increased risk of gestational diabetes mellitus. Previous macrosomic baby of 4.5 or more, previous gestational diabetes, family history of diabetes, first degree relative with diabetes, or ethnicity with a high prevalence of usually Asian ethnicity. To offer women with any of these risk factor testing for gestational diabetes mellitus. So when you found out these risk factor in the patient, then you have to offer her oral glucose tolerance tests as booking. Do not use fasting blood glucose, random blood glucose, HbA1c, glucose challenge test, or urine analysis for glucose to assess the risk of developing gestational diabetes. So the diagnostic test will be oral 75 gram oral glucose tolerance test, a diagnostic test. If you find out that these risk factors are in patient, BMI above 30, previous macrosomic baby, previous gestational diabetes, family history of diabetes, or ethnicity, high prevalence of diabetes. Then in every patient, whenever at booking, we have to do her urinary. At any appointment, you have to advise the patient a urinary. Why we do in every patient HCBC and urinary. So these are very necessary investigation in the women, those who are pregnant, because if HB is low, then it will have a greater impact on both mother and fetus. But urinary is also important, because if there is infection, so there is increased chance of preterm labor, because with the UTI there is increased chance of preterm labor. So that's why we will advise urinary in every appointment. So when you are at booking, when you advise her urinary and you found out that there is glycosuria. So glycosuria detected by routine antenatal testing. Consider further testing to exclude diabetes mellitus in women who have following reagent strip result during the routine antenatal care. Glycosuria 2 plus or above on one occasion, and glycosuria 1 plus or above on two or more occasion. So if you found out glycosuria, then 2 plus on one occasion, and glycosuria of 1 plus or above, or on two or more occasions, so you have to advise oral glucose tolerance test in these cases. Okay, so this is one of the important point, you have to memorize this. Testing. Using the 75 gram 2-hour oral glucose tolerance test to test the gestational diabetes in women with risk factors. So, for women who have gestational diabetes in previous pregnancy, offer early self-monitoring of blood glucose and a 75 gram 2-hour oral glucose as possible after booking, whether in the first or second trimester, and a further OGTT at 24 to 28 weeks if the result of the first OGT is normal. So, in these type of patient, when we have already read these risk factors, if the previously the patient have previously gestational diabetes, but throughout her, then after pregnancy her diabetes are controlled, then when she want to have another then if she is having another pregnancy, then you have to advise her OGTT at booking, and if it is normal, then again at 24 to 28 weeks. If at booking the oral OGTT is not normal, then you have to start her on treatment. But you have to the other differentiating point in that because previously our concept is that in first trimester, if the अगर फर्स्ट ट्राइमेस्टर में आपका ग्लूकोज abnormal आ जाए, then we have to label it chronic diabetes mellitus and in later after 28 week GDM. But whenever the patient have a abnormal blood glucose level in pregnancy, especially in pregnancy, then we have to label her as has gestational diabetes mellitus. So in these cases आप एक baseline आप HbA1c in first trimester अगर आपके पास ग्लूकोज abnormal आ जाए, so baseline HbA1c भी हम करवाते हैं, ठीक है, कि हम ये बता दें कि previous record patient का कैसे था, ठीक है, क्योंकि sometime we miss that maybe the patient was chronic diabetic and we have to miss because patient ने अपना proper follow up नहीं किया, ठीक है. तो at first trimester if the blood glucose are abnormal, then you have to advise her HbA1c when testing also. So diagnosis, how to diagnose gestational diabetes mellitus. The fasting blood glucose level of 5.6 or above, or 2-hour plasma glucose of 7.8 millimole per liter or above. So in that case, you have to tell the patient that fasting for 8 hours, then you have to give her 75 gram oral glucose. Then after that, you have to check her again 2-hour blood glucose level. So if it is more than 5.6 and more than 7.8, so we have to the diagnosis would be gestational diabetes mellitus. So how to memorize 5, 6, 7, 8. So it's one of the SB also. Women who are diagnosed with gestational diabetes offer a review with Point Diabetes Antenatal Clinic within 1 week. Tell their primary health team. Intervention. The implication of explain to the woman with gestational diabetes mellitus the implication both short and long term of diagnosis for her and her baby. So what are the implications of that? The blood glucose control throughout the pregnancy will reduce the risk of fetal macrosomia, trauma during birth, induction of labor, cesarean section, neonatal hypoglycemia, and perinatal death. So in that case, for example, fetal macrosomia and polyhydramnion are mostly associated with just GDM, and IUGR is mostly associated with the chronic type 2 diabetes mellitus. So if the patient present with, if you are diagnosed as gestational diabetes mellitus in pregnancy, so you have to counsel the patient that it will have a certain fetal-maternal implication. So that would be fetal macrosomia, trauma during birth, induction of labor, neonatal hypoglycemia, and perinatal death. Teach the woman with gestational diabetes how to self-monitor their blood glucose level. Use the same capillary blood glucose target level for women with gestational diabetes as for those with pre-existing diabetes. Tailor blood glucose lowering therapy to the blood glucose profile and personal preference of the woman with gestational diabetes. Women who are diagnosed with gestational diabetes offer advice about changing her diet and an exercise. So you have to start initially if the cutoff is 5, 6, 7, 8. If it is more, then you have to start first. The first treatment would be initially you have to start her on glucose, the diet, offer her diet and exercise. If the after 2 weeks you have to review the patient. If the sugar are not controlled, then you have to advise start her on oral hypoglycemic agent. And when you have to start insulin, if the fasting glucose is more than 7 millimole per liter, or random is more than 11 millimole per liter, and those patients having developed complication, polyhydramnia or microsoma, then you have to start insulin. So these are the indication for insulin. You have to get the NICE guideline is a beautiful enough for the exam, but you have to get a quick through SOGP guidelines of diabetes. तो दे दैट वो भी अच्छे हैं, ठीक है, आप उसके गो थ्रू कर लें जो SOGP के गाइडलाइंस है, ठीक है. बाकी नाइस में बड़ा अच्छा इन्होंने सब कुछ एक्सप्लेन किया हुआ है, लेकिन बस जस्ट एक गो थ्रू कर लें, क्योंकि समटाइम्स इन ऑस्की दे मस्ट हैव इन ऑस्की स्टेशन दे हैव टू आस्क अबाउट द SOGP guidelines. So for that you have to get a quick read of that, otherwise the NICE guidelines are enough. Then women who are diagnosed with gestational diabetes offer advice about change in diet and exercise. Advise women with gestational diabetes to give referral all women with diabetes to the dietitian. Advise women with gestational diabetes to exercise regularly, for walking for 30 minutes after a meal. For women with gestational diabetes with a fasting level of less than below 7 at diagnosis, offer a trial of diet or exercise. And if the blood glucose target are not met with diet exercise changes within 1 to 2 weeks, offer metformin. If the metformin is contraindicated or unacceptable to women, offer insulin. And if the blood glucose level are not met with diet and exercise changes plus metformin, offer insulin as well. So in which cases you have to prescribe directly insulin. For women with gestational diabetes who have fasting blood glucose level of 7 millimole or above at diagnosis, offer immediate treatment with insulin with or without metformin and diets and exercise changes. And for women with gestational diabetes who have fasting blood glucose level of between 6 to 6.9 and complications such as macrosomia or polyhydramnia, consider immediate treatment with insulin with or without metformin, diet and exercise. So these points are very, very important, that if her blood glucose level is less than 7, so initially you have to start her on diet and exercise, and after 2 weeks you have to review her. If her glucose are controlled, you have to continue on diet and exercise. And if her glucose level are not controlled, then you have to start her on metformin. But the other condition is that if at initial her glucose level are 7 or more than that, then you have to immediately start her on insulin, not to wait to advise her diet or exercise or metformin. In that case, you have immediately start her on insulin and along with that diet or exercise. But if her glucose level are between 6 to 6.9, but the patient develop complication like diabetes, like macrosomia and polyhydramnia, so in that case, you will also start her immediately on insulin. So these are the important point you have to remember. The SB also came from these lines, and also in exam you have to specify that to for example, in a short case, if the patient having a polyhydramnia and along with diabetes, so in exam if you are plan her management, if you are planning her for management, so in that case you have to start immediately her on insulin, not on diet or exercise. So these are the point you have to memorize, that in which case what you will do. So antenatal care for women with diabetes, monitoring blood glucose level. Advise women with type 1 diabetes to their testing fasting, pre-meal, 1 hour post-meal and blood glucose level daily. So in they advise only 4 level, but if we are admitting the patient, so in that case we will check her fasting, pre-meal, post-meal, pre-lunch, post-lunch and one at night. So these are the 6 level. In our routine, we'll, for example, if the her glucose level are controlled, then you have to advise her take her only 4 readings. But if you are admitting the patient in ward, so in that case we have to take her 6 level of blood glucose level. An exam you have to mention that I want her 6 level blood glucose level profile or if you are saying that I am admitting this patient, then I will start her on 6 level of sugar profile. So these are the differentiating point you have to memorize this. Advise pregnant women with type 2 diabetes mellitus or gestational diabetes mellitus who are on multiple daily insulin regime to test their fasting, pre-meal, 1 hour post-meal and bedtime blood glucose level daily. Okay. Advise women with type 2 diabetes or gestational diabetes to test their fasting, 1 hour post meal blood glucose level if they are managing their diabetes with diets and exercise changes alone, or taking oral therapy with or without exercise changes, or a single dose of intermediate acting or long acting insulin. So they've given a relaxation in that point, that if her sugar level are controlled, then they said that if those having type 2 diabetes mellitus or gestational diabetes mellitus, so they have to check only fasting or 1 hour post meal. If her everything is controlled and she'll manage it by self at home, so in that case you have to tell that she should record of her fasting and 1 hour post meal, managing their diabetes with diet and exercise, and those taking oral therapy or single dose intermediate. If a single dose of intermediate long acting, then you have to advise her only fasting and 1 hour post meal. But if she's taking multiple regime of insulin therapy, that she's already taking short acting insulin along with long acting, so in that case you will not advise her to do her the two readings. In that case you have to advise that she should monitor her glucose level by pre-meal, 1 hour post meal and bedtime. As they already mentioned that who are on multiple daily insulin injection regime. So multiple that they are taking both short acting and long acting, and in those are type 1 diabetes mellitus. In every case, in type 1 diabetes, whether controlled or uncontrolled, to advise the patient, if she is at home, in home regime, she should maintain her pre-meal, 1 hour post-meal and bedtime blood glucose level daily. So these are the differentiating point in this case, that how to monitor blood glucose level in patient with the type 1, type 2 or gestational diabetes mellitus. So what are the target blood level? Agree individual target for self-monitoring of blood glucose with pregnant women with diabetes, taking the account of risk of hypoglycemia. Advise pregnant women with any form of diabetes to maintain their capillary blood glucose level below the target level. If these are achievable without causing problematic hypoglycemia, so what are the target level? In MCQ, they have to ask that after when you have to start her on treatment, what are the target level, and for oral glucose tolerance test, what how to interpret that test. So for if you are in oral glucose tolerance test, in that case, that is 5. 6, 7, 8, less than 5.6, less than 7.8. But you have to start her on treatment, or you have to start her on diet or exercise, then your monitoring level will be different, that how much you have to maintain in these patients. So fasting should be 5.3, 1 hour 1.7 and 2 hour 6.4. So this is one of the SB and exam. They also ask about that especially in OSCE station, what are your target level after starting treatment. So our target level after starting treatment, so in monitoring, that our fasting should be less than 5.3, 1 hour after meal should be less than 7.8 and 2 hours should be 6.4. If these level are increases, then we have to adjust the treatment. Advise pregnant with the diabetes who are taking insulin or maintain their capillary blood glucose level above 4 millimole per liter. If the patient is taking insulin, so you have to tell about her the hypoglycemic symptoms and tell her that educate the patient that when her sugar level should be level should be above 4 millimole per liter. If it is less than 4 millimole per liter, then she have to immediately take some toffee or any sugar type of thing to maintain her blood glucose level, because in less than 4 millimole the patient is in hypoglycemic state. So monitoring of HbA1c level. In whom you will advise how to HbA1c level. So measure HbA1c level at the booking appointment for all women with pre-existing diabetes to determine the level of risk for pregnancy. Considering measuring HbA1c level in the second and third trimester of pregnancy for women with pre-existing diabetes to assess the level for pregnancy. So they said consider, not offer. They said consider HbA1c level in second and third with pre-existing diabetes. So those having pre-existing diabetes mellitus, so at booking appointment you have to do her HbA1c level because she is a pre-existing, she is non-diabetic. So in non-diabetic you have to check her levels, whether her level are controlled or not. If already if the patient is already pregnant and when she came with when you are advised her HbA1c level and it is so much high, then you have to, if it is 8.8, then you have to counsel that she already she's pregnant and her glucose level are high, so there may be chance that the baby may develop congenital abnormalities because you some patient may not done their pre-pregnancy counseling and directly they get pregnant and came to you. So in that case you have to tell the patient that your glucose are uncontrolled and you have not done your pre-pregnancy counseling, so there more than 90% chance that your baby will get congenital abnormalities. So be aware that the level of risk for pregnancy for all women with pre-existing diabetes increase with an HbA1c level above 6.5%. Measures HbA1c level when a woman are diagnosed with gestational diabetes mellitus to identify women who may pre-existing type 2 diabetes mellitus. So they also say that who are diagnosed with diabetes mellitus, so a baseline HbA1c should be done in that patient. There may be a pre-existing type 2 diabetes mellitus in that patient. Do not routinely use HbA1c level to assess a woman's blood glucose control in the second and third trimester of pregnancy. Usually in those patients they are considered in that cases when pre-existing diabetes, but routinely you will not offer HbA1c in second and third trimester of pregnancy. Managing diabetes during pregnancy, insulin treatment and risk of hypoglycemia. Consider rapid-acting insulin as Smart and Lispro for the pregnant woman with diabetes. Be aware that insulin analog have advantages over soluble human insulin during pregnancy. Advise women with insulin treating diabetes of the risk of hypoglycemia and impaired awareness of hypoglycemia in pregnancy, particularly in the first trimester. Advise women with insulin treated diabetes to always having a fast acting form of glucose available, for example, dextrose tablets or glucose containing drink. So they have availability of these drug because there is chance of hypoglycemia. Provide glucagon to the pregnant woman with type 1 diabetes for use if needed. Explain to the woman and a partner or other family member how to use it. So in type 1 diabetes, they are mostly they are immediately develop hypoglycemia if the patient is taking high doses of insulin. So in that case, glucagon must be available and tell the patient that tell the family members that how to use it. Offer continuous subcutaneous insulin infusion also as infusion pump to pregnant women with insulin treated diabetes who are using multiple daily injection of insulin and do not achieve blood control without significant disabling hypoglycemia. So in OSCE station, the examiner also asked about that any other form of insulin forms of insulin available. So one of that is subcutaneous insulin infusions they are very helpful in those they are taking multiple daily injection of insulin. That is very difficult for the patient to prick so many times. So this infusion attached to her arm and they will administer insulin according to her blood glucose level, and those are with significant disabling hypoglycemia, so that option is better for the patient if the patient is affordable. Continuous glucose monitoring. Continuous glucose monitoring. Offer real-time continuous glucose monitoring to all pregnant women with type 1 diabetes mellitus to help them meet their pregnancy glucose target and improve neonatal outcomes. Offer intermittently scan continuous glucose monitoring, commonly referred as flash, to pregnant with type 1 diabetes who are unable to use real-time continuous glucose monitoring. To clear preference is continuous glucose monitoring. Consider real-time glucose monitoring for pregnant women who are on insulin therapy but do not have type 1 diabetes if they have problem of severe hypoglycemia with or without impaired awareness of hypoglycemia, and they have unstable blood glucose that are usually concerned despite effort of glycemic control. So real time glucose monitoring in those having a problem of severe hypoglycemia. And for pregnant women who are using continuous glucose monitoring, a member of the joint diabetic antenatal care team with expertise in this term should provide education and support. Then ketone testing and diabetic ketoacidosis. Offer a blood ketone testing strips and a meter to pregnant women with type 1 diabetes mellitus. Advise them to test for ketonemia and to seek urgent medical advice if they become hyperglycemia or unwell. So ketone DK usually most commonly with type 1 diabetes mellitus. Advise pregnant women with type 2 diabetes mellitus or gestational diabetes mellitus to seek urgent medical advice if they become hyperglycemic or unwell. So in type 1, you have to tell the patient that any time strips may be available with her if because they are, if she unwell become hyperglycemic, she has to check her ketonemia level. But in type 2 diabetes and gestational diabetes mellitus, will not advise routinely the patient to do her ketones level, or but tell the patient that if her glucose level are too high, more than 11 millimole or more than 200, then immediately she came to hospital, and we will advise her urgent medical advice, and we will advise her ketones level. Test urgently for ketonemia if a pregnant woman with any form of diabetes present with hyperglycemia is unwell. Immediate admit pregnant woman with suspected DK, which can receive both medical and obstetric care. Retinal assessment during pregnancy. Offer a pregnant with pre-existing diabetes have their first antenatal clinical appointment. Offer retinal assessment by digital imaging with mydriasis using tropicamide unless they have a retinal assessment in the last 3 months. If they have a diabetic retinopathy, offer additional retinal assessment at 16 to 20 weeks. Offer antenatal assessment at 28 weeks. So if the booking antenatal testing been done, if that was normal, then another assessment at 28 weeks. If that initial assessment was not normal at booking, then you have to another addition of assessment at 16 to 20 weeks. So this was one important SBA, that if the patient has already her retinal assessment has been done at booking and it was abnormal, then you have to repeat her at 16 to 20 weeks. Diabetic retinopathy should not be considered a contraindication to rapid optimization of blood glucose in women who present with a high HbA1c in early pregnancy. Diabetic retinopathy should not be considered a contraindication to vaginal birth. Then renal assessment during pregnancy. Arrange a renal assessment at first contact during pregnancy for women with a pre-existing diabetes if they had not had one in the last 3 months. Consider referring pregnant with women to a nephrologist if these I've already discussed. Urine albumin creatinine ratio of greater than 30, total protein exceeds 0.5 gram per day. Do not use EGFR to measure kidney function in pregnant women because they will usually not very reliable in pregnant women. Consider thrombin prophylaxis for women with nephrotic range of proteinuria above 5 gram. Albumin creatinine ratio greater than 200 milligram per mole. So 5 gram per day is almost, or proteinuria of 5 gram per day and albumin ratio greater than 200 mg per millimole, then you have to consider thromboprophylaxis. So this is also important point and SBA point. Then in home patient, those are having involvement of kidney, you have to prescribe her consider in thromboprophylaxis. So when the proteinuria above 5 gram and the albumin creatinine ratio greater than 220. Preventing preeclampsia. Using antiplatelet to reduce the risk of preeclampsia in pregnant women in diabetes. So in chronic diabetes, you have to prescribe aspirin 75 mg from 12 weeks because they may develop later on preeclampsia, or because it is associated with diabetes. Hypertension is correlated along with it, so these patients may develop preeclampsia, and those having especially renal involvement, chronic diabetes renal involvement, so you have to prescribe her antiplatelet agent. And in chronic condition, especially in chronic hypertensive, you have to when the patient is chronic hypertensive, then you have to prescribe antiplatelet agent from start from 12 weeks to 75 mg. Detecting congenital anomalies. Offer women with diabetes an ultrasound 20 weeks to detect fetal structure anomalies, including examination of the fetal heart, fourth chamber, outflow tract, and these vessels, because usually they have cardiac anomalies. Then, monitoring fetal growth and well-being. Offer women with diabetes ultrasound monitoring of the fetal growth and amniotic fluid cavity every 4 weeks from 24 to 28 weeks. So growth scan will be from 28 to 36 weeks, 4 weekly. Routine monitoring of the fetal well-being before 38 is not recommended in pregnant women with diabetes unless there is a risk of fetal growth restriction. This include methods such as fetal umbilical artery Doppler, fetal heart rate, and biophysical profile. So you will not routinely advise umbilical artery Doppler unless you are suspecting intrauterine growth restriction. So if the patient is chronic diabetic or chronic hypertensive, then you have to do the growth scans are normal. So a baseline at 28 weeks or 36 weeks, we have to do her umbilical artery Doppler so that we can't miss her IUGR. Provide individualized approach to monitoring fetal growth and well-being for disease with diabetes at risk of fetal growth restriction, macrovascular disease, or nephropathy. So in gestational diabetes mellitus, they are less likely IUGR, but in chronic diabetes, because vessels are compromised, so in chronic diabetes, usually the baby may develop intrauterine growth restriction. Organization of antenatal care. Offer immediate contact with joint diabetic antenatal care to pregnant women with diabetes. Joint diabetes antenatal care should be contacted in women diabetes every 2 to 3 weeks throughout pregnancy. This is a beautiful table. It is basically a summary type that how you will booking appointment, what you will do at booking appointment. Usually at 10 weeks, what you will do, discuss the how diabetes will affect the pregnancy, birth, and early parenting, such as breastfeeding and initial care of the baby. If the woman has not had preconceptional care, give information, education, and advice. Take a clinical history to establish the extent of diabetes related complication, including neuropathy, vascular disease, and review medicines for diabetes and its complication. And if the woman had a preconception care, continue to provide information, advice, and achieving optimal blood glucose control. Offer retinal assessment with pre-existing diabetes unless the woman had not been assessed in the last 3 months. Offer a renal assessment for women with pre-existing diabetes if they had one in the last 3 months. Arrange contact with giant diabetes antenatal clinic every 1 to 2 weeks throughout the pregnancy for all women with diabetes. Measure HbA1c level for women with pre-existing diabetes to determine the level of risk of pregnancy. Offer ODTT as soon as possible for women with previous gestational diabetes who begin in the first trimester, and confirm the viability of the pregnancy at 7 to 8 weeks. So they at 16 weeks, what we have to do, we already discussed in detail in that go through with this table only, that what you have to do at which week. So they have repeated you we already discussed in previously in detail. So in that one, the patient present with preterm labor and preterm labor and the preterm labor with diabetes. So diabetes should be considered a contraindication to tocolytics or to antenatal steroid for is not considered a contraindication to tocolytics. So in those having diabetes, you have to give her both tocolytics and fetal maturity. There is no contraindication. For women with insulin treating diabetes who are taking steroid for lung maturity, give additional insulin according to agreed protocol and the woman closely. So when you are starting a steroid, so in these cases the glucose level may be impaired due to because of steroids. There is increased risk of increased level of glucose. So when you are starting her steroid, so you have to increase the insulin dose from her original requirement of her dose. From if for 48 hours if you are giving her steroids, then you have to increase the dose of insulin. Then when her steroid cover is complete, then you have to reduce it to her original insulin level. So this one is also important point. Do not use beta mimetic medication for tocolytic in women with diabetes mellitus. Intrapartum care, timing and mode of birth. Discussing the time and mode of birth they're pregnant with diabetes during antenatal appointment, especially using during the third trimester. Advise pregnant women with type 1 and type 2 diabetes mellitus and no other complication to have elective birth by induced labor or, if indicated, cesarean section between 36 and 38 plus 6 weeks of days. So those having chronic diabetes without any complication, you have to proceed up to 38 plus at least 38 plus 6 weeks. The patient must have to be delivered, but they have given a range between 37 and 38 plus. So ideally, if everything is normal, then you have to wait for at least 38 plus 6 days. Consider elective birth before 37 weeks to women with type 1 or type 2 diabetes mellitus who have maternal or other fetal complication. Usually with type 1 or type 2, they are chronic, so most likely these patient have by babies of usually intrauterine growth restriction. So if these babies develop any complication, and these ladies develop any complication like IUGR, so then your management will be changed. You have to left that you have to treat both diabetes and IUGR. So if according to IUGR you have to treat that patient, that she may need early delivery, because in IUGR there may be absent diastolic flow, whether it is a reverse diastolic flow. So according to that you have to manage this patient and decide her delivery. If everything is normal, you have to leave her for at least 38 plus 6 days. But if any complication, so this is not a clear-cut indication. If there's a complication, you have to deliver at any gestational age, depend upon her maturity, whether the baby is mature or not and needs steroid cover. So according to that, you have to change your management. Advise women with gestational diabetes to give birth no later than 40 plus 6 weeks. Offer elective birth by induced labor if indicated by cesarean to women who are not given by this time. So at least 42 plus 6 weeks for gestational diabetes mellitus. So you have not to proceed further for 40 plus 6. If the patient is not in labor at 40 plus 6 weeks, then you have to do something, whether CTG is normal, then you have to offer induction of labor. Consider elective birth before 40 plus 6 weeks with gestational diabetes who have maternal or fetal complication. Usually patient develop polyhydramnion or the baby is macrosomic usually, so you have to deliver early, because if you have to left that these type of patient, so the may develop complication. Diabetes should not be a contraindication to vaginal birth of a previous one C-section. So if the previous one C-section or the patient have diabetes, you have to individualize your management, whether how is her throughout her pregnancy, how was her control. And usually these patients, those are on insulin, and they have a previous one C-section. So in our setup, it is better option is that you will go toward previous one, because there are two risk factors in that patient, already previous one and diabetes and on insulin. So in that case you have to individualize and depend upon this obstetrician choice and what is the better option for the patient. For pregnant with diabetes who have ultrasound diagnosis, macrosomic fetus, explain the risk and benefit of vaginal induction of labor and cesarean section. If obviously on ultrasound you have to find out that the baby is macrosomic, obviously you have to plan it early, or if the size is not according to that for vaginal birth, so better option in these cases are cesarean section. So it depends. Cases vary according to patient. So you have to change your management according to the patient. What are the risk factors in this patient, and whether we have to proceed for the vaginal delivery, cesarean section. So it's an individual choice, open choice for every month. Then you have to categorize patient, that which patient need this and what. It is not a straightforward rule, because labor is a vast thing that we will not specify this things for that, because anything can happen in obstetric. Anesthesia for diabetes and comorbidities such as obesity, autonomic neuropathy offer an anesthetic assessment in the third trimester of pregnancy. If a woman has GA for the birth, monitor glucose every 30 minutes for induction of anesthesia until after the baby is born and the woman is fully conscious. So if you are planning for cesarean section and anesthesia, or if on spinal, you have to do her cesarean section, then glucose monitoring will be every 30 minutes. Okay. Then blood glucose during the labor. Monitoring blood glucose level every hourly during labor and birth for a woman with diabetes and maintain her 4 to 7 millimole. So these points you have to tell in OSCE station. These are very important. Word to word point you have to tell the examiner that my plan is this throughout pregnancy and after during delivery. If you are planning for cesarean section, then if you opt for cesarean section for the patient in because you thought that this is a better option for the patient, so that you have to mention that while during cesarean section we have to monitor her glucose level every 30 minutes, and her aim of blood glucose level should be at least 4 to 7 millimole, and during labor we have to check her blood glucose level every hourly to aim of 4 to 7 millimole. Consider IV dextrose and insulin infusion from the onset of established labor for women with type 1 diabetes mellitus. Usually type 1 diabetes mellitus we have start her insulin infusion, but in type 2 and type 2 diabetes mellitus and gestational diabetes mellitus, if her glucose level is too high and cannot be controlled, so we have to individualize that. If the sugar level is not controlled, then you have to start her insulin infusion. How to prepare the insulin infusion? We have to 50 cc of normal saline, and we make a solution. For example, you should take a dial flow in which you have to take 50 ml of normal saline and 50 cc of insulin, and you have to give 1 cc per hour the infusion. To keep the blood glucose level of 4 to 7 millimole. If it is less than 4, you have to give her additional extra dextrose solution. If it is more than 7, then you have to give insulin. So you have to balance this situation. Use IV dextrose and insulin infusion during labor and birth for women with diabetes whose capillary blood glucose is not maintained between 4 to 7 millimole. So in type 1 diabetes mellitus, you have to, once in the patient established, you have to start her on IV dextrose and along with insulin infusion. But in one hand the insulin infusion is going on and the other hand dextrose. So you have to balance in between this. The other thing is that what a neonatal care, the neonatal care initially assessment and criteria for admission to intensive care. These are that type of things that we have routinely in our training. We have done this type of monitoring and how to send the baby to the nursery. So these are common things that are very easily for that to memorize it. Advise women with gestational diabetes to give birth in hospital with advanced neonatal resuscitation are available 24 hours a day. Carried out blood glucose routinely 2 to 4 hours after birth in babies of the woman with diabetes. Carried out blood glucose for babies with clinical assessment of polycythemia, hyperbilirubinemia, hypocalcemia, and hypomagnesemia. So these babies may develop these type of complications. So you have to take the blood for these. And perform echo for baby with diabetes if they show clinical sign associated with congenital heart disease, cardiomyopathy, including heart murmur, based the timing examination on the clinical circumstances. Admit baby to the woman with diabetes to the neonatal if have hypoglycemia associated with abnormal clinical signs. So you have to do once the baby, after birth of the baby, you will immediately check her glucose level because these neonate develop hypoglycemia. So you have to monitor this baby. Usually these type of monitoring done in neonatology ward. So those respiratory distress, sign of decompensation from congenital heart disease, sign of neonatal INCAP, sign of polycythemia, need for IV fluids, need for tube feeding, jaundice requiring intensive phototherapy, and baby born before 34 weeks, and assessment of the baby suggests that they do not transfer baby to the woman to diabetic until at least 24 hours old, and you are satisfied the baby is monitoring blood glucose level and feeding. So in our setup, we will usually, once the diabetic mother deliver the baby, then we have to admit in nursery, but they have a criteria because every facility available in other countries, so they have specified that usually neonatal unit babies admit to the neonatal unit, and those having hypoglycemia with the abnormal clinical signs, respiratory distress, and all these points they have discussed in these Then, preventing and assessment neonatal hypoglycemia. All maternities should have a written policy from preventing, detecting, and managing hypoglycemia in baby with diabetes. Testing the blood glucose level of baby of women with diabetes using a quality assured method validated for neonatal ward blood glucose electrode or laboratory analysis. And women with diabetes should feed their babies advised as soon as possible after birth within 30 minutes, and then frequent interval every 2 to 3 hours until fetal maintain their pre-feed capillary should be at minimum of 2 millimole per liter. And often use additional methods such as tube feeding or IV dextrose if capillary blood glucose level are below 2 or on 2 consecutive reading despite maximal support for feeding. And their abnormal clinical sign, the baby will not effectively feed orally. For babies with clinical sign of hyperglycemia, testing blood glucose level and provide IV dextrose as soon as possible. So we are usually routinely we will do follow the protocol of this until they said that if the baby tell the mother that she should start her feed as soon as possible, feed per interval of 2 to 3 hours to maintain her blood glucose level above 2. If the blood glucose level below 2, then you have to admit the baby and usually start her on IV dextrose as soon as possible. So postnatal blood glucose control medicine and breastfeeding. Women with insulin treated pre-existing diabetes should reduce their insulin immediately after birth and monitor their blood glucose to find the appropriate dose. So in pre-existing diabetes, we will reduce the dose to half, almost 50%. But in gestational diabetes, we will stop that and start her on 2 hourly blood glucose level and to check that whether she need further treatment like in the form of insulin or glucose. Then we have to calculate her whole insulin requirement if she needed. But in chronic diabetes, we will usually reduce our insulin. But in gestation diabetes, we are going to stop her insulin level and check her glucose level. Explain to women with insulin treating pre-existing diabetes that they are in risk of hypoglycemia in the postnatal period and advise them to have a meal or snack before or during feed. So we are, and this in diabetic patient we have to break the NBM early as soon as possible because in these patients there are chances of hypoglycemic risk, and also tell that while breastfeeding she should take a meal or snack because with that feed she may develop hypoglycemia. Women who have been diagnosed with gestational diabetes should stop blood glucose therapy immediately after birth. As I've told you, women with pre-existing type 2 diabetes who are breastfeeding can resume or continue metformin immediately after birth, but should be avoid other blood glucose lowering therapy while breastfeeding. So metformin is safe, and in that case in type 2 diabetes, if patient is taking insulin, then we have to reduce her dose of insulin. Then women with diabetes who are breastfeeding should continue to avoid any medication for their diabetic complication that was stopped for safe reason when they are planning the pregnancy. So that type of drug like AC inhibitors, ARBs or statins, we have to stop before pregnancy. So you have to not to give while during breastfeeding. So you have to refer these patient to multidisciplinary team like endocrinologists, or so they can manage further accordingly to that. Information about follow-up after birth. Women with pre-existing diabetes. Offer women with pre-existing diabetes back to the routine diabetes care arrangement, and you have to refer back to a respective physician. Remind women with diabetes of the importance of contraception and need for preconception care when planning for further pregnancies. So women diagnosed with diabetes. Before women who are diagnosed with gestational diabetes are referred to community care, test their hypoglycemia to pre-existing hyperglycemia. Remind women who are diagnosed with gestational diabetes of the symptom of hyperglycemia. Ensure who are diagnosed with diabetes about the risk of recurrence in future pregnancy, and offer them diabetes testing when planning future pregnancy. So you have to tell the patient that there is increased chance of that she developing diabetes mellitus in next pregnancy. So pre-pregnancy counseling is very important. Whether she has a plan for a baby, then she has to come for pre-pregnancy counseling, and in that we will offer her booking OGTT when she gets pregnant. For women who are diagnosed with gestational diabetes and whose blood glucose level return to normal after birth, offer lifestyle advice including weight control, diet and exercise. Offer a fasting blood glucose at 6 to 13 weeks after birth to exclude diabetes. For practical reason, this might take place at 6 weeks postnatal. So you have to advise her that she should come at 6 week postnatal, and we will advise her to do her fasting blood glucose level. And now, or after 13 weeks, offer a fasting blood glucose if it has not been done earlier, or HbA1c test if fasting glucose test is not possible. So if the patient have not done her she has not came to at 6 week, then you have to offer her at 13 week. And if the fasting is not available, you offer her HbA1c. Do not routinely offer 75 gram oral glucose tolerance. So you have to memorize it that initially we have to do postnatally at 6 weeks. We will do our 70 advise her 75 oral glucose tolerance test, but they said that do not offerly routinely this 75 gram to oral. You will advise her fasting is sufficient for this type of patient. And then for women having fasting blood glucose level as the postnatal test, advise with a fasting level below 6 millimole, that they have a low probability of having diabetes at the moment. If the fasting should be less than 6 millimole, then you have to tell that she should not worry. Low probability of diabetes at that moment. They should continue to follow lifestyle modification, and they will need annual tests to check their blood glucose level are normal. So those having a moderate risk of developing type 2 diabetes mellitus, offer them advice guidance with type 2 diabetes mellitus. So less than 6, tell that there is a less chance that she may develop chronic diabetes. But if her fasting glucose level between 6 and 6.9, tell that they are high risk of developing type 2 diabetes mellitus, and offer them advice guidance intervention. Advise women with fasting level of less of 7 millimole or above, they are like to have type 2 diabetes mellitus, and offer a test to confirm this. Okay, then you have to offer the test for confirmation. For women having HbA1c test at the postnatal test, advise women with HbA1c level below 5.7. If, for example, the fasting blood sugar is not available, and then you have to offer her HbA1c. If the patient came with HbA1c report that I have done HbA1c, then it is okay. So for HbA1c, it should be less than 5.7. So you will tell that there is a low risk, low probability of having diabetes, and she should maintain her lifestyle modification, and annually she have to check her HbA1c level. But advice with HbA1c level between 3.9 to 4.7 millimole, that is 5.7 to 6.4, so that are high risk of developing type 2 diabetes mellitus, and offer them advice according to the NICE preventing type 2 diabetes. So in that case, you will advise the patient that she to check her blood glucose level, offer her dietary advice to control her on diet, because her glucose level is high, and according to that you will refer her to physician, and she may need oral hypoglycemic agents. Advise women HbA1c level of 6.5 or above, that they have type 2 by diabetes mellitus, and refer for further care. So 5.7 to 6.4, you have to tell that she should continue her diet and dietary modification, and continue her testing. If it is more than, and if the test came out to be more than 6.5, then you have to refer to endocrinologist or physician, and immediately start her on treatment, because it is 6.5%. And because in this patient, if you have not to start her on treatment, then the sugar level should be uncontrolled in these patients. Offer annual HbA1c test to women with gestational diabetes who have negative postnatal test for diabetes. So annually you have offered her HbA1c testing for those who are gestational diabetes, and offer women gestational diabetes early self-monitoring of blood glucose or OGTT in future. Offer a subsequent OGTT if the first OGTT result in early pregnancy are normal. So OGTT usually not offer postnatally, but if the patient is planning for pregnancy, so at booking you will offer her OGTT. Otherwise, annual HbA1c testing, or annually you can those diabetes mellitus, annually you have to follow her glucose level. Thank you so much. Hope you find the lecture good. And if you have any queries, kindly comment on this lecture, or you have to send message on WhatsApp group. Thank you so much.